Mm-mm. Yep.
Good morning, Giselle.
Good morning. How are you?
I am fine, and you?
Hanging in there.
Morning, Giselle.
Good morning.
Good morning.
Good morning. Almost everyone's here, so we'll start in just a minute.
Unit 5 PowerPoint is not available on Blackboard.
What? Let me put that up there right now. Thanks for letting me know. Okay. Were you guys able to access the study guide?
No.
Oh my gosh. Okay. Oh, I see. Okay. It should be open now, the PowerPoint. And let's see the study guide. Oh, great. My computer froze. All right, I'll get it up there after class. Has anyone been having issues with Blackboard, or is it just me? Every time I go to the grade center, it freezes.
Lots of issues.
Okay, good. I'm not the only one. We're going to Canvas in the fall. It's a different platform. I hope it's better. All right, let me pull up the PowerPoint here. Okay. So before we get started with the PowerPoint, did anyone have any questions about the pretest?
I did.
Okay.
It was the one with the fluid and electrolyte imbalances
Okay, let me take a look.
that was associated with Addison's.
Uh-huh.
In the book, it showed some that were just associated with Addison's, but then there was another little part that was like the Addisonians, the crisis part of it.
Mm-hmm.
And that included the hypercalcemia. So I wasn't really sure what the right answer was.
Okay, let's see. Fluid and electrolyte imbalances associated with Addison's disease include which of the following? Select all that applies. So I said page 1025. Let's see. All right, so the answer was hyperkalemia and hyponatremia.
But if you look in the book, it says hyperkalemia promotes hydrogen ion retention. Metabolic acidosis also can occur.
Mm-hmm.
And wasn't metabolic acidosis one of the...
Yeah, it was. Let me take a look at this question. I'll mark it down.
And then it was also like I was really confused because then if you looked under the Addisonian crisis,
Yeah.
I wasn't sure if that was to be included because in an Addisonian crisis, I believe that's where the hypercalcemia was at. And it was on page 1026.
Yeah, this question specifically is just asking about Addison's disease. Because the crisis is when it's exacerbated. So just regular Addisonian disease, like when it's stable, is what it's asking.
Okay.
But the hypercalcemia, I'll have to look into. And then I'll change the answer if I find the right answer. And what was the question?
Can you also tell us what the answer was for the NPH insulin question?
Yes. Okay. So the insulin is hard, you guys. I get it. For this one, there's a little chart on page 1071. So, sorry, 1070. So it says the patient is taking NPH insulin at 8 a.m. What time of day should they be provided a snack in order to prevent hypoglycemia? So it says here the onset. So you guys have to know what onset and peak means. The onset is how long it will take to start working, right? So 1 to 3 hours is what it says. And then the peak is when it's at its highest level of effect, I guess, is 6 to 10 hours. And it can last 12 to 16 hours. So the answer was 4 o'clock. And then there's on page 1071, there's a little formula there. So usually, and we'll talk about insulin and diabetes more extensively next week, but usually the patient will get the short acting insulin in the morning because they've been without coverage all night. They'll get a fast acting insulin in the morning right before breakfast, and that will hold them over usually until dinner time. But you check the blood sugar at lunch because they might need some additional coverage. And especially if they're getting the long acting insulin at the same time, then they kind of work together. One works over a long period of time and that one's the short acting. So anyway, I will go into it next week. But for this one, the onset is what you were looking for. Or sorry, the peak. Does that make sense? Not really.
When does actually you start going down on the blood sugar? Is that at the peak or just right after the peak?
The blood sugar down after the peak.
Is the peak where it's most effective?
Mm-hmm.
Okay.
Yeah. The peak effect is that it's when its highest effect, if that makes sense.
So, but if you're looking at when do you need the snack, do you really look at the peak or after the peak?
Right around the peak time. So 6 hours, 6 to 10 hours. The latest time on this question, the option was 4 o'clock because it's 9, 10, 12, and 4. So if we give it at 8 a.m., if we look at the onset, it's 1 to 3 hours. So 9 a.m., 10 a.m., and even noon is too early. So the only option left in that question would be 4 o'clock. All right. Any other questions about the pretest? Okay, I will look at that Addison's question, and we'll go from there. Okay, can everyone see the PowerPoint before I start talking?
Yes.
Awesome. And let me just write this down here from the chat. Okay. All right, so this unit, I'm not gonna lie, is the hardest one. Not a fan of it, so let's get through it together. So it's in the endocrine system. We'll start with the pituitary and adrenal disorders. So the endocrine system is made up of several organs. Let me just get my stuff situated here. Let's see who's here. Okay. So we've got the thyroid, parathyroid, the pituitary, adrenal glands, the pancreas, and the testes and the ovaries. Those are all of the glands that secrete hormones. And they act on different things happening to the body. So they're like a stress response. So if something happens, then the glands are triggered to release hormones. And that is all to keep the body in homeostasis. So they want the balance of all of the hormones. So that is what that blank is over there, homeostasis. And it responds to fluid and electrolyte balances and different things happening outside of the body, like temperature, for example. And then they also act on growth and development. There's hormones for that too. So the functions and regulations of the hormones, it acts as a negative feedback process. If you think about your thermostat, for example, if you set it at 75 and your house is at 80, it's not going to keep going up because then it'll be too hot. So it just goes up until the temperature is achieved. And that's kind of how the endocrine system works. And it could be positive or negative feedback. So the hormones can be triggered to release more to balance it out, or they can be suppressed to release less to balance out the functions of the body. So here is a chart of all of the glands and how the hormones work. And this is just a broad overview, kind of a refresher from anatomy and physiology. Just to refresh, I won't be asking anything specifically of what gland secretes what, but basically the pituitary gland in your brain is the boss. It's the one that controls, that releases the hormones to activate the release of hormones from all the other glands. So it'll signal hormones to activate the release of hormones from the thyroid, the parathyroid, the adrenal, and then the ovaries. And that's all of the disorders that we'll talk about in this unit, is when there's an issue with hormone release in each one of these glands. So then the first one we're going to talk about is the pituitary gland. It's located in the sella turcica in your brain. So basically it's up there. It's not your thyroid or anything else. That is the one that is the boss that I talked about. It's connected to the hypothalamus. It's pretty small, and it has two lobes, the anterior and the adenophysis. So the larger of the two lobes hold 70 to 80% of the gland. That's just for your curiosity. There's a really good video that I posted in your resource folder for this unit that kind of explains everything. I'm a very visual learner, so that helps me understand, and it has pretty cute little drawings of glands and everything. So if you're interested, you can watch that. Okay, so then the anterior lobe of the pituitary gland secretes these hormones. So we got growth hormone, the ACTH, adrenocortical hormone, thyroid stimulating hormone, TSH, follicle stimulating hormone, that's the FSH, luteinizing hormone, we usually call it the LH, prolactin, and then the melanocyte stimulating hormone. So the growth hormone obviously stimulates growth. In development, the adrenocorticotropic controls growth development and some of the functions of the adrenal glands. The TSH controls the thyroid glands. The FSH stimulates the development of eggs in the ovaries of women and sperm production in the men. Prolactin stimulates breast milk production, and then the melanocytes promote skin pigmentation. And then the posterior lobe of the pituitary gland, which is the smaller one, it secretes vasopressin, so ADH, and oxytocin. The ADH works to reabsorb water in the body from the renal tubules of the kidneys, and then it decreases urine secretion. So it helps you helps you prevent dehydration in the body. And then the oxytocin, we've probably heard of it in maternity, not my specialty, but anyway, Pitocin, that causes contractions in the uterus when a woman is in labor. And it also works to release breast milk. So if somebody comes in with a pituitary gland issue, part of your assessment, why they're seeking care. So you want to know if they have had any issues with growth, visual disturbance, headaches, changes in urine output, appearance in the skin, and secondary sex characteristics. And these things are going to come in here in the next few slides. And really important, the majority of the issues with the pituitary gland happen because of brain tumors. So make sure you know if they have a history of that, or any head trauma, head surgery, things like that, or any family history. And also a family history of diabetes insipidus. So the health history of the pituitary gland, we want to make sure.
You're feeling frustrated.
Oh, somebody's talking. Let's see. Okay. So you want to ask them about the things that can be affected by hormones. So have they been feeling tired lately? Have they had any changes in the way their hair grows? Are they extra hairy now? or if they have grown disproportionately, things like that. Joint pain, seizures, that would be from the brain tumor. There is page 1008 in your book, box 46-1, outlines all of these assessment guides. And then you want to ask them about their functional state. So have they been sleeping too much, having trouble sleeping? Have they changed anything in their diet? Are they all of a sudden eating a lot more than they used to, or they're not eating at all? Or maybe they're eating a lot and they're losing weight and they don't know why. And then also note the effect that this illness is having on their self-concept and usual activities. The physical assessment, this would be just like any other regular assessment, but you want to pay attention to the things that would be related to hormones. So anything related to the sex hormones, hair growth, body growth, and we'll talk about that here in just a second. Visual acuity, all of these things. As far as age-related changes, in the older adult, in the healthy older adult, the pituitary function remains the same. So there's not really any degeneration that occurs with age, but they have diminished response to ADH. So that is that hormone that maintains your hydration status. And then the decline in the growth hormone, the secretion of the growth hormone, because they're already fully grown, they reduce in protein synthesis, decreasing the lean body and bone mass, and then it reduces immune function as well. So the diminished response to the ADH makes the older adult less able to compensate for inadequate fluid intake or excessive fluid loss. So for us, for a younger person or somebody that doesn't have pituitary gland disorder, if we are doing an activity where we're losing a lot of fluid, the ADH controls like how much we're sweating so we don't lose too much fluid, and the same the other way around, but with the older person it doesn't work as well. So as far as diagnosis of pituitary gland dysfunction, they can do imaging studies, so CT, X-ray, MRIs, and this will detect if there is a pituitary tumor. And then a cerebral angiography, that is when they do anything with contrast. An angiogram, that's the word for that. So they inject dye into the arteries to see if there's any blockages, arterial venous malformations. You might hear about this being called AVMs, that is arterial venous malformation. And that is just when there's like a tangle in the vasculature. You might see that even in the stomach or the colon, and sometimes they bleed. So that could cause issues. All right, as far as labs, you might have heard of this, maybe remember from Unit 1, I know it was a long time ago, but the ELISA test, it measures the levels of hormones in the blood, so that is something that they can draw. And then they can also do what is called suppression or stimulation tests. So the way that that works is if they suspect that there's a deficiency, they will give a medication that stimulates the release of that hormone. So let's say if they think that there's an issue with growth hormone. So then they'll give the medication, and in a healthy pituitary gland, if they're doing the stimulation test, it'll stimulate the pituitary to release more growth hormone. If they're doing a suppression test, they will give a medication that suppresses it, and in a healthy pituitary gland, it'll suppress the growth hormone. But if it's not working, then it'll have the opposite effect. So, disorders of the pituitary, the first one we're going to talk about is hyperpituitarism. So if you can imagine, that is when it is stimulating too much release of the growth hormone. And not only the growth hormone, it could also be the prolactin, FSH, LH, and ACTH. the most common reason is pituitary adenoma, so a tumor in the pituitary gland. Usually it's a benign tumor made out of epithelial tissue, and it's more common in young women in their 30s. So the tumor may either inhibit or stimulate the release of the growth hormone. It's very rare to have dysfunction where there's too much or too little FSH or LH being released. So usually it's a problem with the growth hormone, which is called hyperpituitarism. But if it is a problem with the other hormones, so if it's prolactin, which is the hormone that stimulates breast production in women, they can have prolactinemia. So that's excess prolactin being released. So what does that mean? That women will have abnormal lactation, they might have their periods suppressed, vaginal dryness, decreased libido, depression and anxiety, and then visual disturbances. Then the growth hormone, we talked about a little bit, it stimulates the growth and development of bones, muscles, and organs, and it also mobilizes fat storages for energy use later. If there is too much growth hormone, then free fatty acids in the bloodstream accumulate, and that puts the person at risk for developing atherosclerosis. If you remember from the last unit, that is when the fat buildup inside the vessels narrow them, and that puts the patient at risk for hypertension, strokes, things like that, because if it's too narrow, then it's impeding blood flow to those vital organs. So overproduction of growth hormone can lead to gigantism or acromegaly. So those are the two disease processes that result from the overstimulation of the growth hormone. The main difference here between these two is that gigantism occurs in early childhood or puberty. So what that means is that their bones never stop growing, and the growth is proportional. And then and this happens because the bones are still growing, so that's why it's proportional. With acromegaly, that usually happens when the patient have the macroadenomas, which is the tumor in the pituitary gland, or compressing it in that region. This happens much later on in life, and then because the patient is usually already grown, they're not still growing like in gigantism, the growth is not going to be proportional. The bones, instead of growing long, they're going to grow wider, and it can affect their organs. So their heart can be enlarged, it'll affect their digestive system, nervous system, and genitourinary systems. So for signs and symptoms to remember, the first initial symptoms that usually present is visual deficits and headaches. And that is going to be due to the pressure in the optic nerves that affect the person's vision. Then they will have enlarged hands, their feet, and paranasal and frontal sinuses. So I'll show you a picture here in a minute, but it'll be very distinct. And they can have soft tissue enlargement, so their tongue, their liver, their spleen, and if their tongue is so overgrown, it can affect their speech. And then they'll have increase in fatigue and weakness, and organomegaly, like I talked about, their internal organs can be enlarged, and they can also have excessive perspiration, oily skin, peripheral neuropathy, degeneration of joints because of the overgrowth of the bones, and then proximal muscle weakness. So here's a picture of gigantism. So this guy here, he's only 22, or I mean, he died at 22, so I don't know how old he is here, but pretty young guy. And as you can see, he's proportional relatively speaking, I guess. His legs are really long. But anyway, the growth is steady and proportional when it happens in their early years. And then in contrast, you have acromegaly. So this is the same person as she aged. So you can see that her face is pretty normal. And then you start seeing her facial features get really wide, her jaw gets wide, and her hands are really big. So that's the difference there. It's not proportional growth. So I included in this PowerPoint some of these little pictures. Like I said, I'm a very visual learner, so that kind of helps me remember all of the differences between these. And I think for your clinical, some of you are doing the patho-based concept maps, and that will really help too. Because then you have one sheet with everything you need to know about the disease process, basically how it's diagnosed, what are some nursing interventions you do, risk factors, blah, blah, blah. So if you're making those, hold on to them so you can study for the NCLEX, because they'll be handy and it's your own doing, so you'll remember doing it. It'll reinforce your learning. Anyway, oh, somebody's coming in. Okay, so it is believed that Abe Lincoln had gigantism. He was a very tall man. And then these are the clinical manifestations here, everything we talked about. So medical diagnosis, they will do a CT scan or MRI. And then they can do hormone studies to see if there is a dysfunction and how much it's released, if it's releasing too much. So one test that they can do is called dexamethasone suppression, and that can rule out problems with dysfunction of the adrenal glands. So what it does is it measures cortisol, which increases with adrenal hyperplasia or Cushing syndrome, which we'll talk about in a few slides. And then the MRI can help detect any lesions or tumors also. So for the medical treatment, several drugs can be used. So somatostatin analogs, dopamine agonists, and growth hormone receptor antagonists. One that is common is octreotide or sandostatin, which is the most commonly prescribed drug for acromegaly. How it works is that they give them 3 times a week in a sub-Q injection. So it suppresses the growth hormone to try to slow down that overgrowth that happens. But it can also suppress insulin secretion, so it needs to be closely monitored. Those people will have to have their blood sugars checked. They can have radiation, so that will treat the tumors that are pressing against the pituitary gland and causing problems. And then they could also have surgery to remove the adenoma of the pituitary. So with the surgery, it's called a hypophysectomy. So they go in and they make an incision right above the lip there between the nose, and they spread it up and go in there right in the pituitary gland and remove the tumor. So after they do that, they have to put it's not really a dressing, but what they do is they get some adipose tissue from the person's abdomen and they put it in there to kind of stop the bleeding and hold it in place and prevent leakage of CSF. So remember that that's unique to this surgery is they use a piece of adipose tissue to close up the site where they went in. And then they put gauze in the nasal passage to prevent drainage. Usually it's called a mustache dressing, and you have to assess it to see if CSF fluid is leaking. So if there is clear drainage in the mustache dressing, that is a warning sign that probably is a CSF leak. One thing that is important to remember here. So with this, they removed the pituitary gland. So they'll need hormone therapy for the rest of their lives. And also, as you can imagine, they can't do any forceful straining because that could dislodge that adipose tissue that is in there. So no forceful coughing, straining for bowel movement, anything that increases pressure, vomiting. So make sure their nausea is under control. All of these things can increase intracranial pressure and cause problems. So as far as your assessment, you want to assess for those things that we talked about. Is their growth proportional or not? Do they have those facial features? How is their speech? Is it their tongue so swollen that they're having issues speaking, or maybe they're having issues eating? And then for the surgery, make sure you know what the patient knows and expects and provide them teaching about all of the things that we talked about. No forceful coughing, vomiting, all of that. So as far as interventions and nursing diagnosis, disturbed body image, so obviously due to the changes in the physical appearance, activity intolerance, these patients tend to tire quickly. So kind of like the patients with liver disease, you want to encourage activity, but then also periods of rest. So you want to plan their day so they can have those periods of rest. Chronic pain, this is due to the musculoskeletal overgrowth that can cause pain in their joints. And then ineffective self-health management, they will have to have medications or hormone replacement therapy for the rest of their lives. So making sure that they understand that they have to take those medications, make sure they understand what times and what route, everything, so they can take care of themselves. Self-health management, medication management. So then for the hypophysectomy, the postoperative nursing, oh, sorry, Diana's texting me. Oh, talk to her later. So the postoperative nursing assessment for the pituitary gland removal, you want to closely monitor their level of consciousness. What are we looking for here? Any signs of increased intracranial pressure. We want to monitor their intake and output pretty closely. They're at risk for SIADH or diabetes insipidus, which we'll talk about in a few slides. Inspect the nasal packing. I talked about this a little bit a couple of slides ago. And then signs and symptoms of infection. Obviously, they just had a surgery. So LOC, if you remember from the last unit, the pupil size inequality, are their eyes perla, their vital signs, how's their blood pressure. As far as infection, monitoring your labs, how is the white blood cell count, and if watch out for a fever. If they have a fever, let the doctor know right away. And then the nasal dressing, the mustache dressing I was talking about, if they have clear, colorless drainage, you have to notify the surgeon because it could be a CSF leak. So what they'll do is take a sample of the drainage and send it to the lab to test it for glucose. The cerebrospinal fluid is very high in glucose. So if that fluid comes back positive for high glucose, that means they have a CSF leak, so they have to go back to surgery. Because if they're having a CSF leak, that is gonna affect their intracranial pressure. That's the halo effect, yes, that is correct. Because the drainage on the dressing will have a little halo around it, a little circle. Okay, so then for after the surgery, as far as nursing diagnoses, anxiety, obviously. So you saw the picture, it looks pretty scary, going in there in your brain and taking your pituitary gland out. So educating the patient about the procedure, how it's gonna go, how it's gonna look after, and the things that they have to do, easing your patient's fears. And then also teaching them about their medical management and the changes in their life they'll have after the surgery. Decreased intracranial adaptive capacity. So this is talking about these cerebrospinal fluid leaks and everything, changes in intracranial pressure. So you want to make sure you're monitoring for any vision changes, really good neuro checks here, level of consciousness, and then explain that sometimes the visual disturbances might not be corrected, but they are being prevented from further exacerbating. Acute pain, for obvious reasons. So pain in the face, that could be really hard for some people to deal with. And then also, because they have all that stuff in their nose, they're gonna have a hard time breathing. They're gonna have to breathe through their mouth. So frequent oral care is really important, and just educating them, you know, that it's gonna be different to breathe for a while. So impaired oral mucous membranes, their mouth is gonna be dry. Risk for injury. So this has to do with the increased intracranial pressure, all that potential coughing or vomiting, things like that. We don't want that package, the nasal packing, to come out. So be very careful. Excess fluid volume or fluid deficit. So we want to monitor eyes and nose pretty closely, and the dressing. And then risk for infection, as with any surgery. Hypopituitarism. So the opposite. There is not enough secretion of the growth hormone. What happens here is dwarfism. So the same thing as before, like if it happens before, while they're still growing, looks one way, and then after it looks a different way. So dwarfism is when the person is still pre-adolescent, so they're still growing. They won't grow to their full potential, I guess. It'd be 40% below normal. And this could be, the cause is either hereditary, or if there's damage to the anterior portion of the pituitary gland. And panhypopituitarism is when growth has been completed, but some pathological process impairs the function of the pituitary gland, and then it affects all the other hormones. So signs and symptoms will depend on which hormones are deficient. Dwarfism occurs earlier in life, but they will have proportional physical characteristics. So they'll have the exact opposite problem of gigantism. They will have delayed or absent sexual maturation. As you can imagine, if it's just happening before puberty, then they'll never reach puberty. Question. Is there a physical difference between the pituitary gland issue, dwarfism, and a hereditary? No. It is the same effect. So they also might have developmental delays, and then usually just because they're shorter and don't grow doesn't mean that they don't age. So usually they age faster and have a shorter lifespan. So with panhypopituitarism, what could happen is Simmons cachexia, which is a syndrome that occurs when there's muscle and organ wasting and disruptions of both digestion and metabolism. The absence of the ACTH affects the person's ability to cope with stress. So an example is hypoglycemia will occur. The TSH is depleted, so they will have hypothyroidism, and that affects their ability to control their body temperature. And they'll have decreased pigmentation of the skin due to the lack of the MSH, so they will be really, really pale. And the last thing is the gonads may be atrophied, so they will, because of the absence of gonadotropin. So the panhypopituitarism is when all of their hormone secretions are affected. So all of these effects occur. So for medical diagnosis, health history, you want to know if there's a hereditary component. They'll do CT scans and cerebral angiography like we talked about. So that will detect any pituitary or cranial tumors or AVMs, the arteriovenous malformations. And then the serum levels of pituitary hormones, they'll do those suppression or stimulation tests that we talked about a little bit ago. And then medical and surgical treatment, they have a hormone deficiency, so they can replace the hormones that are deficient. So a prime example is for thyroid stimulating hormone deficit. They do Synthroid or levothyroxine, which is a medication that stimulates release of the TSH from the thyroid. And then if it is caused by a tumor, they can do surgery to remove it or radiation to shrink it. So for an assessment for the hypopituitarism, you want to assess their mental acuity, their emotional stability and affect. So like we said a couple of slides ago, they might have some developmental delays that you would look out for. And you want to note their energy level and appetite. And then compare their current height and weight measurements to previous measurements. Are they growing as they should be following that curve, or are they kind of stunted? So that will give you a background to tune you into this potential issue. And then if they have any difficulty carrying out their usual activities. So interventions, same as with the hyperpituitarism, so education. There's stigma, you know, with growth, suppression and all of that. So making sure that they have support groups or listening to their concerns. And then pay attention to their nutritional status, fluid balance, educate them. And then also on the prescribed therapy that they might be taking replacement hormones for all of those deficiencies that we talked about. So making sure that they know what they're taking, when they need to take it, things like that. And then encourage their expression of their feelings and concerns. They might need mental health counseling and other resources like that. So those are all anterior pituitary disorders. And now we're going to talk about posterior pituitary disorders. So this is characterized by either too much or too little ADH production. And that, if you remember, is what maintains fluid balance. So it keeps you in a state of hydration. And the ADH specifically causes the reabsorption of water from the renal tubules in the kidney. So the disorders associated with dysfunction of this is either diabetes insipidus or SIADH, which is syndrome of inappropriate antidiuretic hormone. So what happens if there's too much ADH release, then your water retention is increased, and then the opposite effect if there's not enough. So with diabetes insipidus, has nothing to do with blood sugar. It is when there's excess output of dilute urine. So you're losing a lot of fluids. And make sure you know the difference between the different kinds. So there's nephrogenic, neurogenic, and then dipsogenic. With nephrogenic, that is when there is sufficient ADH amounts produced, but the kidneys don't respond to it adequately. So then there's a dysfunction. And it could be due to certain drugs. So lithium carbonate is one of them that can have this effect. The neurogenic is when there's a defect in either the production or secretion of ADH. So that could be because of a hypothalamic tumor, head trauma, if there's an infection, if it was damaged during a procedure, or if there's a metastatic tumor. Or it could also be triggered by a stroke or intracranial hemorrhage. And then the dipsogenic is a disorder of thirst stimulation. So when the patient drinks water, the serum osmolality decreases, and then it leads to the reduced vasopressin ADH secretion. So that could be a result of excessive water intake or psychiatric conditions. So the pathophysiology, the ADH, either there's not enough being produced and secreted, or the kidneys are not responding to it. So then there's going to be a lot of loss of water. So what are the signs and symptoms? The distal tubules in the kidney are not reabsorbing sufficient water, so they'll have massive diuresis, dehydration, and thirst. They'll have decreased intravascular volume because they're losing all of that fluid. So what does that mean? They'll have low blood pressure, and when the blood pressure drops, the compensatory mechanism will increase their heart rate, so they'll have tachycardia, and they'll have dizziness. So hypotension, tachycardia, and dizziness are the classic symptoms of diabetes insipidus. Remember that. They can also have lethargy, malaise, weakness, and irritability. So pay attention to their level of consciousness. It will be decreased. And then they could also have an irregular heartbeat, and that is because of the electrolyte disturbance. So they could actually have cardiac arrest. Oh, and one thing, you might hear the term polyuria. That just means excessive urine. So for the diagnosis, it is done with the health history and labs. And then they'll do what is called a 24-hour urine specimen. And what they're looking for is if there's more than 4 liters of urine in a 4-hour period. I don't know if any of you guys have done that as CNA, but the patient basically has to collect all of their urine in this big orange jug, and they send it to the lab and test it. So what they're looking for in the lab is the urine will be so dilute, they'll do the test that is called specific gravity, and it will be really low. And the osmolality in the urine is also going to be decreased when they test it. As far as medical treatment, fluid replacement, they will do vasopressors when the pressure is really low. For neurogenic, they can do DDAVP, which is a desmopressin. And then for nephrogenic, they will do sodium restriction and then thiazide diuretics. So one thing to remember with the neurogenic, there's a problem in the production and secretion of ADH, and then medication is used to treat it. And then the nephrogenic, that is an inherent defect that does not respond to ADH. So giving him medication is not going to work because the kidneys don't respond to ADH. So for their assessment, they're going to have excessive thirst. Their urine will be very, very clear, and a lot of it. They'll have the symptoms of low blood pressure, low volume, so dizziness, weakness, they could faint. Orthostatic hypotension is an issue, so make sure that you're having them rise from a sitting or laying position slowly so they don't fall. And they'll have heart palpitations because the heart is trying to compensate for the decreased volume. Skin turgor is important to look at. So another sign of dehydration, mucous membrane, so inspecting their mouth, and then also their heart rate, the pulse, is their bounding pulse, is it weak and thready? Blood pressure, obviously, and then the mental status. Are they all of a sudden really dizzy and lethargic, things like that. And then we want to keep a real close eye on their daily weights and eyes and nose and the urine specific gravity, if that is something that is ordered regularly. So as far as nursing diagnosis, deficient fluid volume, for obvious reasons, so we're monitoring their eyes and nose, daily weights. Anxiety and disturbed body image is due to the changes in bodily function. Activity intolerance, they're going to have extreme fatigue and muscle weakness because of the dehydration. So make sure they're having periods of rest, and then slowly, sorry guys, Diana is calling me and I'm just going to say, I'm lecturing. Okay. And then ineffective self-health management, they have to be really aware that they have a potential to have dehydration and fainting and all of these symptoms, and even cardiac arrest if they lose too many electrolytes. So keeping up with their medications, and this will be for all of these disorders, making sure they know when and how to take their meds and stay on top of them. So then I have a graphic here to help you remember. So the pituitary gland there is trying to control the secretion of ADH hormone, and the kidney is just losing a bunch of water. And then, you know, history of head injury, pituitary tumor, craniotomy. This is just to help you study. Helps me anyway. Okay, so then the opposite is SIADH, which is a syndrome of inappropriate antidiuretic hormone. So this could be water imbalance because of increased ADH secretion or synthesis, or both. So some factors that can lead to development of SIADH can be brain trauma, brain surgery, or tumors that are compressing on the pituitary gland, infections, or some drugs, or some types of cancer. So the types of cancer that can lead to this will be small cell lung cancer, duodenal cancer, and pancreatic cancer. I'm pretty sure there's not any questions on this exam about this, but you want to remember those cancers that can cause SIADH, because you might get an NCLEX question on this. So the pathophysiology is when the ADH is either elevated, it's elevated because of normal or low serum osmolality in the kidneys, and they retain excessive water. So the plasma volume expands, and then the blood pressure rises. So the opposite of diabetes insipidus. And then sodium is diluted, so they have hyponatremia, and then they have water intoxication. So instead of losing all that water, they have way too much. So here's a little graphic to help you remember this one. There's a small cell lung cancer. That's really the main one to remember that is associated with this. So signs and symptoms, they'll have weakness, muscle cramps and twitching because of the electrolyte disturbance. They can have anorexia, nausea, diarrhea, irritability, headache, and weight gain without edema. So the central nervous system will be affected by water intoxication, so then the level of consciousness will decrease. And they could have a seizure or even end up in a coma. So the lab tests, they will test the serum and urine electrolytes and osmolality, and then they'll do radiographic studies in the brain or the lungs. So they're trying to detect if there's a tumor, if there's lung cancer, any of those things that might cause SIADH. As far as the diagnosis, they'll measure those two things simultaneously, and the urine osmolality will be much higher than the serum osmolality. So then that will confirm the diagnosis of SIADH. So then as far as the assessment goes, the major characteristics will be hyponatremia, so low sodium, low chloride, hypochloremia, and then their BUN and creatinine clearance will be reduced, and they have fluid volume excess, but without edema. So then the medical treatment will be focused on correcting the cause, and then promote elimination of all of the excess water. When the patient is acutely ill, which means that they have neurologic symptoms, they will give them hypertonic saline, and then we'll do it very slowly over 4 to 6 hours. Once the symptoms resolve, then they'll implement chronic therapy. So as you're noticing with all of these, there will be long-term either hormone replacement or some sort of medication that they have to take to balance it out. They also can have loop diuretics be administered if the sodium level is at least 125 milliequivalents per liter, because the diuretic will cause further loss of sodium. And then with the chronic therapy, you want to restrict their fluids and maintain high intake of sodium, or administer normal saline and loop diuretics. And if they can't adhere to a sodium restriction, they might have to get lithium carbonate. That medication blocks the effect of ADH on the renal tubules, and then they increase the water excretion, so they won't hold on to so much water. So as far as your assessment, nausea, vomiting, diarrhea, headache, irritability, and muscle cramps and weakness because of the electrolyte disturbance. Assess for any history of cancer or any of the other causes of SIADH. Make sure you know what prescription drugs they're taking to see if it's a result of a medication. You want to make sure you're monitoring their intake and output pretty closely, and daily weights, and also specific urine gravity, and also the vital signs. You want to test their muscle strength and see if they have any history of seizures, muscle weakness, twitching, or cramps, or even if the patient's already in the hospital and they're having exacerbation of SIADH. If they're telling you, oh, I have twitching in my muscles or have leg cramps, that's something that you want to notify the doctor about, because they might need some electrolyte replacement. And then describe the mental status. So neuro assessment will be key here. You want to do it at least every 4 hours. So nursing diagnoses for these patients. Teaching will be very important. So teach them about the importance of daily weights. We want to make sure they're not holding on to too much fluid. And they want to notify the physician if they have weight gain of more than 2 pounds in 24 hours. And then teach them about the signs and symptoms of water retention. So if they have any drowsiness, headache, on page 1011 and 1022 on your book, there is a chart with all of these signs and symptoms. So as far as nursing diagnosis, risk for injury, they can have neurological impact, so they can get confused. Make sure that safety precautions are in place. So fall risk, put the socks on the patient, and make sure that they know to ask for help if they need to get up. Excess fluid volume, and they might have to restrict their fluid intake. So make sure that you're keeping up with that and educating them. You've had this much fluid today, you can only have this much more. Don't keep a water pitcher at their bedside, because that just encourages increased fluid intake, especially if the patient is confused. And then ineffective self-health management. So this condition may not resolve completely during the hospitalization. They will probably have to self-manage at home. And this is with anything. We want to reduce the length of stay in the hospital. So people get sent home pretty quickly. So make sure they're prepared and set up for success. Okay, so then we're moving on to the adrenal glands. So that is two small triangular shaped organs, and they're in the retroperitoneal superior poles of each kidney. When I was in nursing school, my pathophysiology teacher called them the kidney's backpack. So I will never forget where they are. And they each weigh about 4 grams. So they're very small, right on top of the kidney. And they have 2 parts. So there's the cortex and the inner portion that's called the medulla. So the medulla portion of it has 20% of the gland, and it has the secretory cells. They do the stimulation of the sympathetic nervous system, and then secretes 2 catecholamines. So that will be the norepinephrine and then the epinephrine. So those are 2 neurotransmitters that we learned about last unit. So these substances, they adapt to stresses called the fight or flight response or the resting and digestion. So the parasympathetic nervous system and then the sympathetic nervous system, fight or flight response, all of those things. Then the cortex is the majority of the adrenal gland. That is the portion that is considered part of the endocrine system. So it's essential for maintaining many life-sustaining physiological activities, and it has 3 zones: the glomerulosa, fasciitis, and reticularis. The hormones are synthesized and secreted by the cortex. They're steroids, and they consist of mineralocorticoids, glucocorticoids, and androgens or estrogens. So the mineralocorticoids, they are produced in the zona glomerulosa, and their job is to maintain extracellular fluid volume. The most abundant of these mineralocorticoids is the aldosterone. So the aldosterone functions in the kidneys, in the tubules, so they promote the reabsorption of sodium and excretion of potassium by the kidney. And then the secretion of aldosterone is regulated by several factors in the body. So the potassium level, the ACTH, and then the renin-angiotensin mechanism. So this renin-angiotensin and aldosterone cascade, so each step triggers the next one in the cascade, and it's initiated by a decrease in extracellular fluid volume. So then when that happens, the renin activates the release of plasma proteins to angiotensin 1, and then it is catalyzed in the lung to angiotensin 2, and then that stimulates the secretion of aldosterone, which then results in sodium and water retention. I have a little chart. So an example of what would activate this is, let's say over here, the blood pressure drops, or there's a decrease in blood volume. So then the kidneys activate the renin system, which then activates angiotensin and angiotensin 1 in the lungs, and the vasoconstrictor to hold on to fluids, and then the aldosterone acts on water and sodium retention. So, the angiotensin 2 occurs in the lungs, and then the adrenal glands secrete the aldosterone. So then the glucocorticoids are secreted by they're produced by the zona reticularis and zona fasciculata. The most abundant and potent of these is cortisol. You have probably heard of that before. 92% of it is circulating, is bound to a plasma protein. And it has a permissive effect on the physiologic processes. So it must be present for that to occur, such as catecholamine activity, excitability of the muscles in the heart. And it also acts to control carbohydrate, lipid, and fat metabolism, and the regulation of anti-inflammatory and immune responses, and control emotional states. So then the adrenal glands, here is a little graphic to help you remember the hormones that are secreted by those. So the SSS, sugar is the glucocorticoids, salt is the mineral corticoids, and then the sex is the androgens. So that primary function of those obviously is masculinization in men, and then the other sex hormones, the estrogen and progesterone. In men, they contribute little to reproductive maturation, and in women, it's supplied by the ovaries and the adrenal glands. In postmenopausal women, the adrenal cortex is the primary source of endogenous estrogen. So then with dysfunction of the adrenal glands, we want to know what symptoms brought the patient to the hospital. So are they having changes in their energy level? Are they having changes in their mood? Are they having changes in their sexual function? Gastrointestinal disturbances, or are they having any abnormal skin pigmentation? And then we want to know if they had any radiation to their head or abdomen, intracranial surgery, what medications are they taking, is some of that causing an effect on these hormones. And then tuberculosis is the most common cause of primary adrenal insufficiency. So you're going to know from their history if they have had that in the past. So they'll have, when you're doing a skin assessment, they might have a bronzed appearance or smoky pigmentation. Women will have increased facial hair. No any changes in their appetite or weight. And then they might also have headaches, lightheadedness with position changes. So the orthostatic hypotension, muscle weakness, if they're having any nausea and vomiting, abdominal pain. And then with the sex hormones, are they having any amenorrhea or menorrhagia? Are they having erectile dysfunction? And then as far as functional assessment, with all of these, you want to know if there's any changes in their diet. Are they losing weight without trying, gaining weight without trying, any disruptions in their lifestyle? So as far as an assessment, you want to, we talked about the hair, abnormal hair growth and skin pigmentation. You want to also examine the oral mucous membranes for color changes. And then you want to inspect, and I'll show you some pictures here in a minute, but they'll have some characteristic findings, such as what they call a buffalo hump. There's accumulation of fat right between the shoulders and the back. If they're having a disproportional weight, so if all of their weight is concentrated in their trunk, if they have striae on their breasts or darkening of the areola, or in their abdomen if they have striae, or in their legs. And then are they having hair loss, and then the appropriateness of their genitalia for their age. So as far as age-related changes with the adrenal glands, they don't really change in the older person. They might have some decline in cortisol secretion, but that is usually balanced with cortisol metabolism, and then the secretion of aldosterone and plasma renin may decline. So their ability to conserve sodium and adapt to position changes becomes less efficient. So then as far as the dysfunctions, the first one will be Addison, so that's adrenal insufficiency, and that could be primary or secondary. So the primary adrenal insufficiency is when a destructive process impairs the adrenal glands. So then that will lead to deficiency in cortisol and aldosterone. The most common cause is idiopathic atrophy, which is autoimmune disease, where adrenal tissue is destroyed by antibodies formed from the patient's immune system. So then that will cause diseases such as, other causes could be diseases of fungal infections, so like TB, AIDS, metastatic cancer, adrenal toxins, or hemorrhage. The other kind is secondary adrenal insufficiency, and that is a result of the dysfunction of the hypothalamus or pituitary gland. Then that leads to decreased androgen and cortisol production. The aldosterone, however, might not be affected, unlike in Addison's, where both are affected. And then for the secondary causes, they could be caused by pituitary tumors, radiation therapy, high dose or long-term glucocorticoid treatment. So the pathophysiology, there's not enough adrenocortical steroids, and that causes defects associated with the loss of those steroids. And also the impaired secretion, so there's not enough being made and there's not enough being secreted, and that decreases the gluconeogenesis, which decreases liver and muscle glycogen. So both of those decreases the supplies of available glucose in the system, causing hypoglycemia. So hypoglycemia is associated with Addison's. And then when the pathophysiology is decreased aldosterone, then their clearance of potassium and water and sodium absorbed by the kidney is impaired. So decreased potassium excretion leads to hyperkalemia, which leads, it promotes hydrogen ion retention. So then that can lead to metabolic acidosis. So that question in the pretest was wrong. I will fix that for you guys, because metabolic acidosis can occur. I just have to make sure it doesn't say alkalosis. Okay, so symptoms. They'll have progressive weakness, they'll be tired, they might have some abdominal pain that is unexplained, and they'll have that bronzed skin, hyperpigmentation. And then if they have decreased aldosterone, they'll have loss of their bodily axillary and pubic hair. They might not have facial hair growth or pubic or axillary hair growth as they're hitting puberty. And then it depends on the degree of the hormone deficiency, how much of that will be affected. And those symptoms are more common in primary renal insufficiency. So then with Addison's, what can happen is an Addisonian crisis, which is a life-threatening emergency. So that is when there is a significant decrease in the available adrenal hormones. So what can lead to those? Adrenal surgery, pituitary destruction, abrupt withdrawal of steroid therapy, which we talked about. All of these disorders require lifelong replacement. So if they forget to take it, or maybe they're having a hypoglycemic episode where they lose consciousness and they don't take their medication, so that can further exacerbate the problem. And also stress. And by stress, I mean anything that can disturb bodily functions, not just like them being stressed out because of their work or whatever, but it could be because of illness and trauma also. So the acute adrenal crisis, how the presentation will include symptoms of mineralocorticoid or glucocorticoid deficiency. So they will have severe hypertension, tachycardia, dehydration, confusion, hyponatremia, hyperkalemia, hypercalcemia, and hypoglycemia. The management for this is in page 1026, page 46.4. Yeah? Oh, I thought somebody had a question. So if they don't get treated, they can have fluid and electrolyte imbalance, and then that affects their circulatory system. They can have arrhythmias because of the electrolyte deficiency, and they can have cardiac arrest and coma, all possibly leading to death. So it is a life-threatening emergency. So for diagnosis, they will do lab studies to check their serum and urinary cortisol levels. They will do a fasting glucose to see if they have hypoglycemia, and then they'll test their electrolytes to look for low sodium, high potassium, or increased BUN. And they'll test the other corticosteroids as well, such as ACTH concentration and cortisol levels in the blood. The echocardiogram, that will let them know if there's any electrolyte dysfunction. So as far as potassium, for example,
What do you think?
if they have hyperkalemia, they'll have peaked
What
T.
always comes with Q.
A year.
Yes.
Sorry. There we go. Okay, so they'll have a peak T wave, wide QRSs, and increase in the PR interval. So if you're looking at their EKG, you will see note those differences if they have hyperkalemia. And then as far as imaging studies, they'll evaluate the skull. They can do arteriogram, CT scan, and MRI to rule out any other causative factors of adrenal insufficiency. So if there's any tumor or injury or things like that. So for treatment, it can be treated with medication. So obviously replacement therapy, which most commonly is used, is hydrocortisone. And then, and that is used because it contains both glucocorticoid and mineralocorticoid. As far as Addisonian crisis, that is treated with IV fluids, hydrocortisone, electrolytes. They can be given dextrose, and all of those things are to restore the normal blood pressure. So as far as your assessment, you want to monitor for weight loss, nausea, vomiting, cramping and diarrhea, muscle weakness and aches, poor stress response, decreased libido. And then their skin assessment. You want to note the hair, the color, skin turgor to evaluate for dehydration, and their blood pressure and muscle wasting. And also the patient may be irritable or confused. So then I have a little picture of what Addison's looks like. So her skin is a little bit bronzed. She has some facial hair here, postural hypotension, so their blood pressure will be low, will drop when they get up. They'll have weight loss, weakness, hypoglycemia. And then the adrenal crisis, here's what their labs will look like. So as far as nursing diagnosis for Addison's, Ineffective tissue perfusion. So you want to monitor them for any confusion, disorientation, any signs of low fluid volume. So tachycardia, if there's an apical radial pulse deficit, any general weakness or malaise, and risk for injury. We talked about the orthostatic hypotension. So you want to check the orthostatic blood pressure. If they complain of dizziness, it's probably what it is. Imbalanced nutrition, less than body requirements. So we want to increase sodium in their diet and then monitor for hypoglycemia. So we want to provide snacks. As far as fatigue, conserve energy, disturbed body image, that is just coping with physical changes. So the pigmentation of the skin and the abnormal hair growth, that can be disturbing. Stress management, as far as the ineffective self-health management. So they want to be able to recognize the signs and symptoms of any crisis, be either psychological or illness related. And then we also want to monitor for any signs of hyperkalemia, so weakness, paresthesia, dizziness, and changes in their EKG. There is a patient teaching box on page 1030 that outlines some of the teaching for these patients. Okay, so before we go into Cushing's, let's take a 10-minute break. So let's see what time it is. Let's come back at 9:40. Okay, we will start back up. I don't remember if I started talking about Cushing's yet. Okay, this is the first slide. So Cushing syndrome is another disease process with the adrenal glands. So that is when there is over-secretion of the adrenal cortex. So they produce excess corticosteroids, in particular the glucocorticosteroid. One of these conditions is called Cushing syndrome, and that is when there's excessive cortisol. So the overproduction can either be internal or external. So internal is endogenous and external is exogenous. As far as endogenous causes, it could be because of tumors. It could be because of a cortisol secreting neoplasm within the adrenal glands, or if there's carcinoma of the lungs or other tissue, then it causes excess secretion of corticotropin. As far as exogenous cause, external causes, that could be because of prolonged administration of corticosteroids. And this is actually the most common cause of Cushing syndrome, is the exogenous cause. So as far as clinical manifestations, that it affects most body symptoms. So is due to the excess level of circulating corticosteroid. So they'll have hyperadrenalism, which produces marked changes in personal appearance. So they will have obesity, facial redness. Hirsutism is excessive hair growth. They'll have menstrual disorders, hypertension, muscle wasting of the extremities. They have a pretty characteristic look to them, and I'll show you a picture here in just a second. Also, they will have delayed wound healing. They might have insomnia. They might have an irrational behavior and mood swings, particularly irritability and anxiety. So you will see this on test questions for this class in the NCLEX. all of these things that are characteristic of Cushing's. So truncal obesity, they carry most of their weight around their midsection. Protein wasting, their extremities would be significantly thinner than their trunk, where they carry most of their weight. And they'll also have very thin and friable skin. The facial fullness is referred to as a moon face. And then they'll have this striae in their
So you can
abdomen.
put your pants on.
I don't know. Here we go. Okay. Then, the striae, the purple markings are going to be on their abdomen. It could be on their breasts, their thighs, or buttocks. And then they are at risk for osteoporosis. This will be most common, particularly in women who are premenopausal. And then they'll have unknown cause hypokalemia. So this is what they present like. So the moon face will have that round shape to their face. Most of the weight is in the trunk here, and the arms and legs are slender. And then this fat deposit here in the back in between the shoulders, that is what is referred to as a buffalo hump. So you'll see that in some test questions in the NCLEX. So medical diagnosis, they will do a 24 urine collection, and this time they're looking for free cortisol. Then they'll do a low-dose dexamethasone suppression test to suppress the secretion, and then if it keeps secreting, then there's an issue there. As far as labs, they'll have polycythemia, hypokalemia, hypernatremia, hyperglycemia. So if you remember with Addison, they have hypoglycemia. With Cushing's, they have hyper. Leukocytosis, glucosuria, hypocalcemia, and elevated plasma cortisol. There's an excess of cortisol. So with imaging studies, the CT will detect if there is any tumors that are causing this, and then the X-rays can detect if there's osteoporosis of the bones. And as far as the dexamethasone suppression tests, in people with normal function, the cortisol is suppressed, but if they do the test and the levels are not suppressed, then they will keep raising the dose to test if they will suppress or not. So then as far as medical treatment, some drugs that they'll take is Lysidrin. That is palliative medication for inoperable tumors. Then the other ones, the Nizoral, Cytidrin, and metoprolol, those all interfere with cortisone production. The other therapy they can have is radiation. So that is if there is a tumor, they will do radiation to shrink the tumor. Or surgical management will be removing the tumor. So this is a little graphic to help you remember Cushing's. So they have that moon face, they'll have hyperglycemia and personality changes, the truncal obesity, and their extremities will be really thin, and then the purple striae could be in the legs, in the abdomen, and also the fat deposit in the back, buffalo hump. So as far as assessment, physical examination, you will look for those characteristic presentation that we just talked about. And then you want to know as far as their history, like when did these symptoms start, if they had any prior treatments with steroids. Do they have to take them for a long term for any other disease, because that is the primary cause of Cushing's. As far as nursing diagnosis, risk for infection that is because they have decreased resistance to infection, and that is with anybody that has to take corticosteroids for a long time. That is one of the effects. Anxiety, that will be due to the personality changes and then coping with their illness, with all of the adaptations that they have to make to their life and the changes to their appearance. Impaired skin integrity, their skin is very fragile, so teaching them to take care of their skin. Risk for injury, so same reason, their skin being fragile, and also because fractures can occur easily due to osteoporosis. Disturbed body image, those characteristic findings that we just talked about, and also ineffective self-health management, so teaching about their medications that they'll have to take and things like that. And there's a box on teaching on page 1033 in your book if you want to reference that. So then as far as surgery, they could do an adrenalectomy. So if they do have that procedure, you want to monitor for and correct any electrolyte imbalances, monitoring eyes and nose pretty closely, EKG for those peaked waves and QRSs and all of that. You want to do everything you can to prevent infection. So teach them to wash their hands. And also before surgery, you want to discuss, hey, you're going to have to take glucocorticoid medications to replace, and then all the dosages and schedules and complications, such as increased risk for infection, for example. So then post-operative care, these patients are usually monitored in the ICU for a couple of days. So you want to monitor them for signs and symptoms of hypotension or impending shock. Their blood pressure will be pretty unstable for the first couple of days after surgery, so they might have to be on pressors to maintain their blood pressure. They pay attention to their pulse closely. They might have a weak or thready pulse. Watch for decreased urinary output and any changes in level of consciousness, which can indicate increased intracranial pressure. And then because of their high risk for infection, because of their disease process, and because they just had surgery, you want to do aseptic technique for wound care, assess their comfort and treat with opioids, and that's for any surgery. And then you want to instruct them to turn, cough, and deep breathe, and use the incentive spirometer so they don't have any pulmonary complications. Since they are more prone to infections, you want to prevent pneumonia, so make sure they're doing their coughing and deep breathing. Another condition is a pheochromocytoma. And that is when there is a benign tumor in the adrenomedulla that causes excessive catecholamine secretion. So the patients will exhibit episodes of hypertension, and their blood pressure will be pretty significantly high. They'll have hypermetabolism and hyperglycemia. The classic finding as far as the hypertension goes is their diastolic blood pressure will be 115 or higher. And another, excuse me, common presentation is the headache is really, really bad, like a pounding headache, because their pressure is so high. And they also have diaphoresis. So this can be triggered by emotional stress, exercise, if there's any manipulation of the tumor for whatever reason. It can be due to postural changes, and then any surgeries or trauma. And then they treat it by surgical removal of the tumor, which is usually done laparoscopically. So here is a little graphic to help you remember pheochromocytoma. There's not a whole lot of information in your book about it, but they'll have the classic headache, sweating and flushing, anxiety because the blood pressure is so high. And then they'll diagnose it with a 24-hour urine sample. to check for creatinine and free catecholamines. But basically with pheochromocytoma, really high blood pressure, and it's a benign tumor. All right, thyroid and parathyroid disorders. So as far as the anatomy and physiology, so your thyroid is located in the anterior portion of your neck, and it's made up of two lobes, so one on each side. And they're connected in front of the trachea by a narrow bridge of tissue, which is called the isthmus. So the thyroid is what controls metabolism and growth and development. And it produces the thyroid hormone, which is a T4, the triiothyroidine, which is a T3, and then calcitonin. The T4 and the T3 increase the metabolic rate, and then the calcitonin helps to regulate calcium levels in the blood. So here is a picture of where the thyroid gland is located, right in front of the neck. There is the isthmus, and it's right in front of the trachea. As far as age-related changes for the thyroid gland, hypothyroidism increases with age, especially with women. So the serum levels of T4 remains about the same as the person ages, but the T3 declines. So they could have, with older people, these symptoms can be overlooked because the symptoms with thyroid disturbances are kind of vague. So if you think about, like, they'll feel really tired, and it could be just dismissed because, like, oh, I'm getting older, so I'm getting tired, and that's normal. So pay close attention to older adults that have these new symptoms. So they might have, with hyperthyroidism, they could have irregular cardiac rhythms. They might have heart failure, weight loss, and muscle weakness. Again, kind of vague symptomology, so further testing is recommended with older adults. So don't dismiss their complaints as related to age. It's normal. It's not, might not be. Okay, so as far as health history assessment, this will be important to know any changes. So are you now all of a sudden really tired when you weren't before, or are you really, really hyper? Are you sleeping a lot or not sleeping enough? Are you able to concentrate or not? And then am I just like crying all of a sudden at everything? Any emotional state changes. And then also weight changes are going to be significant here. Because of the hormones affecting the metabolic rate, they are those people that either they're eating a whole lot but not gaining weight, or barely eating and then they can't lose weight. So those kind of things are important to note. That will clue you in and there's a thyroid problem potentially. And then in the review of systems, you want to know any changes in menstrual cycles, sexual function, hydration, if they have any bowel changes, or tolerance of heat or cold. So depending on which one they have, and we'll go over the breakdown of hyper and hypothyroidism, but they're either going to be really, really hot all the time or really, really cold all the time. And then the hormone deficiencies, they alter the metabolic rate. So if there's a deficiency, the metabolic rate is lower, which will lead to weight gain, despite whatever they're doing to try to change their eating habits. And then the hormone excess increases the metabolic rate, and that will lead to weight loss. And one thing to know, usually thyroid disorders are difficult to detect because the changes are subtle usually. and then the symptoms are kind of vague. So unless it starts to really bother the person, sometimes they won't seek medical care until it's pretty advanced. As far as the physical examination, so vital signs will reflect the metabolic rate. And you want to note the height and weight specifically for all the things that we just talked about. Facial expression and characteristic, as well as mental alertness. So with hypothyroidism, they'll kind of have this depressed kind of affect, and then hyperthyroidism is the opposite. Inspect their skin for temperature, moisture, their hair texture, if it's thin and brittle or really thick. The eyes, examine the eyes. Do they have bulging of the eyeballs, or their neck, they might have goiter. And then observing for tremors, which could be one of the effects. This will be really apparent when you hand the patient a medication cup. If they can't hold on to it, those fine hand tremors will be really apparent there. So make sure they don't drop all their meds on the bed. Okay, so then as far as diagnosis, they will test the serum TSH and free T4 in the blood. Those are the most useful tests to detect an abnormality of the thyroid. Then they'll do the thyroid releasing hormone, the TRH stimulation test. So they will measure the blood levels for this test after they administer TRH. So that will diagnose if there's any disorders of the gland itself, or if there's an issue with the production of the hormones by the hypothalamus. They could also do the RAI, radioactive iodine uptake test. Because iodine concentrates in the thyroid, they can measure what the iodine they inject in the body, and they will accumulate in the gland. So that is typically used to detect cancer in the thyroid, because the accumulation of the iodine in the thyroid gland would be higher if they have thyroid cancer. And then ultrasound will detect any nodules in the thyroid. MRI and CT will detect if there's any metastatic disease in the thyroid. So with hyperthyroidism, there is an abnormally increased synthesis and secretion of the hormones. This is referred to as Graves' disease, and it's the most common type of hyperthyroidism. It is an autoimmune disorder, and that is when antibodies activate the TSH receptors, they stimulate the thyroid enlargement and hormone secretion. This is most common in young women. The multinodular goiter, which will be the enlargement of the thyroid gland, is more commonly seen in women in their 60s and 70s. The hyperthyroidism likely is developed when people have had a goiter for a number of years, the enlarged neck, and then it's caused by small thyroid nodules that secrete excess thyroid hormone without TSH stimulation. So they're kind of just going rogue. The increased hormone production is independent of the TSH, and the nodules in the thyroid can be benign or malignant. With the multinodular goiter, the symptoms are usually less severe than in Graves' disease, where there's an excessive secretion and synthesis. So the signs and symptoms, there's a little picture to help you remember. These are all going to be related to the increased metabolic rate, and it can be range from mild to severe. So like we were talking about, so some of the things can be kind of subtle and hard to detect depending on how severe it is on the person. With mild hyperthyroidism, they may only have weight loss and nervousness. So that could be attributed to, especially in young women, 20 to 24, which is the most common, they're probably just starting their careers or in college still. So nervousness can be just dismissed to stress, and then weight loss, who doesn't like that? They'll probably not be upset about it. So when it becomes more advanced or more severe, then they'll be hot all the time. Their hair will be really fine and brittle and straight. This is when that bulging of the eyes occurs, when it's called exophthalmos, and their eyeballs are kind of coming out of their face. And I'll show you a picture in a minute. They'll be flushed, they'll have tachycardia, muscle wasting. They might not be getting their periods because of the hypermetabolism. And this is where they will display the tremors, fine hand tremors. So we just talked about all of this with the severe hyperthyroidism. They'll also have some changes in bowel patterns. They might have light sensitivity, and something to take note of with the weight loss, we mentioned this earlier, they might be eating a whole lot but never gaining weight. That is one sign that will clue you in there's a problem. And then with the exophthalmos, that's a classic sign of Graves' disease. They can also have tearing because the eye is coming out, like their eyelids might not close all the way, so they have dryness in the eye, and it's also more susceptible to injury. And the bulging of the eyes is caused because of accumulation of fat, edema and inflammation under the eyes. So then the orbital contents will get pushed out. And as far as tachycardia, their heart rate might be as high as 160. There it is, the exophthalmos. I had a teacher, art history class, that her eyes were always like that. Pretty scary. But anyway, they will need eye drops and ointments if they are not able to close their eyelids to protect their eyes. So complications, if untreated, it can lead to, got a question. Can they blink? Yeah, the function of the eyelid is not affected, but if it's really severe, they can blink, but it doesn't close all the way. So that is where the potential for eye injury. And if this person is in the hospital, if they are going through some surgery where they're paralyzed, they're especially at risk for eye injury. Will they have watery eye? I don't think so. I think their eyes are dry because they have the excessive sweating and hot all the time. So more than likely dry eyes. So with the complications, they could have thyrotoxicosis if it's untreated. That is when there is excessive stimulation of the elevated thyroid hormones, and that will lead to dangerous tachycardia and hyperthermia. They will be really restless, and they can even lapse into a coma. This is a medical emergency. It's a rare complication because modern medicine, we have pretty good medications to control for this. So it's important to teach the patient all the medications that they have to take to keep this from happening, but it's certainly a possibility. So then the medical diagnosis, they will have TSH and elevated serum T4. That is the measurement of the thyroid stimulating antibodies. So they'll do the radioactive iodine uptake test, and that's how they diagnose Graves' disease. Sometimes the TSH might be so low that they are not able to detect it in the blood. And then as far as medical treatment, they will get anti-thyroid drugs. So there's 3 methods: medical, radioactive, and surgical. So as far as the drugs, the thiamides and iodines, they are often used temporarily before surgery, and these can cause neutrophil suppression. Then another thing to know with these, they might be given for several months or years, and it takes a while for them to actually take effect. So one adverse effect of this is that it can cause gastric upset and discoloration of the teeth. So make sure that they have food in their stomach when they take these medications. As far as radioactive iodine, that is, it accumulates in the thyroid gland and it causes destruction of the thyroid tissue. So the radiation that they get from that is not one that causes a threat to others, like the ones that we talked about in Unit 1. And it's a really low dose, so the side effects are minimal, but they might have some inflammation of the parotid glands. And then the surgical treatment, which is the most common, is a subtotal thyroidectomy. So they just remove the thyroid gland to solve the issue. So then for the patient that is not doing surgery, for your assessment, these patients are mostly treated as outpatient. So it's important to teach them how to adapt to their condition until the treatment brings relief. As you can imagine, like we talked about, it takes a while for these medications to take effect. So reassuring them that it does take time and it's normal for it not to start working right away. So that is understanding the treatment and assessing their skin texture and edema, measuring vital signs and weight, making sure the blood pressure is not too high. And also note any appetite changes in weight and food intake, because they're gonna be losing weight no matter what. And then nursing diagnoses, decreased cardiac output. This would be due to the increased heart rate and blood pressure. Disturbed sleep pattern, they will often feel restless and have trouble sleeping. So encourage them to arrange their day to allow periods of rest. Discourage them from taking naps, because that can disturb their sleep pattern even further. So teaching them to avoid caffeine, because they're already hyperstimulated. They don't need any help being even more stimulated. And then teaching them to go to bed at the same time every day. That usually helps them establish a sleeping pattern. So adhering to a bedtime schedule, trying to regulate their sleep. Hyperthermia, that will be their heat intolerance because of the metabolic state. So they're going to be hot all the time. So just teaching them, things you can do for that. Wear loose, light colored clothing. For imbalanced nutrition, less than body requirements, encourage to increase the caloric intake. So their diet actually might be required to eat 4,000 to 5,000 calories a day, as opposed to the 2,000 that's normally recommended for people that don't have hyperthyroidism. Risk for injury, so like I talked about, the exophthalmos, they will need lubricants and eye drops to protect their eyes. Impaired comfort, so kind of the same things with their eyes. They'll have light sensitivity, so recommending dark glasses when they go outside, and then using the eye drops. And then another nursing diagnosis is diarrhea, so that can lead to electrolyte imbalance. So they might need antidiarrheals, and then just keep a close eye on their electrolytes. So then the patients that do have a surgical treatment, so a thyroidectomy, that requires a little bit of teaching prior to the surgery to make sure that they understand the care after. Then that is the priority with teaching preoperatively. So they want to understand the preoperative procedures and the postoperative procedures to decrease their anxiety. Because having surgery right there in the neck can be pretty stressful. So as far as postoperative teaching, they'll have a dressing on their neck. So you want to teach them to avoid straining the neck so they don't cause that incision to open. They have to support their head when they're rising from laying down. And then as far as your assessment, you want to document the respiratory status, level of consciousness, check the dressing for any drainage, excessive bleeding, and then the voice quality, comfort, and neuromuscular irritability. One thing that is important to know is the parathyroid glands. They're pretty close located to the thyroid, and these sometimes can be either accidentally removed or nicked during surgery when they do a thyroidectomy. And the parathyroid is responsible for maintaining the serum calcium. So if they get removed accidentally, they will have hypocalcemia and they're at risk for tetany. So that will lead to muscle contractions and twitches and painful cramps. So that's another thing that you want to assess for, especially because the most dangerous complication of this will be spasm of the larynx, and that compromises their airway. So you want to make sure you're keeping an eye on that. So then the post-op thyroidectomy care, there's a little graphic to help you remember there. And as far as nursing diagnoses, so ineffective airway clearance, you want to teach them to turn, cough, and deep breathe, but the coughing might cause stress on the suture line because it's right there on your neck. So you want to have suction equipment readily available on the bedside, because if they're not able to clear the secretions, you can just suction it out so they don't have to forcefully cough. Another thing that you want to have is a tracheostomy set at the bedside, and that is just for an emergency situation. If the airway becomes compromised, the doctor will come in and it's right there. They can just do a trach and get the patient breathing again. Laryngospasms, like we talked about, due to the hypocalcemia or damage to the laryngeal nerve during the surgery. So they might have changes in their voice temporarily because of how the larynx is manipulated during the surgery. And then another nursing diagnosis is decreased cardiac output. So you want to check the dressing frequently for bleeding. And then also you want to check behind their neck. So if they come back from surgery, they're laying down, the incision's right here on their neck, the blood might be just flowing back behind their head. So in the front of the dressing, it might look okay, and you have to assess behind their ears and the back. They might all be pulling right there. So make sure you assess all of the areas to see if there's any bleeding. Disturbed body image is related to the scar. So they will have a small scar on their neck, but it takes a while for it to kind of lighten up and the patient to get used to it. So just explain that to them, that they'll have that scar there, but it will become really light and probably hard to notice as it heals. Acute pain, so they are going to have pain meds. You want to stay on top of those. And risk for infection, so that is due to the incision. Teach them to protect their incision like we talked about. Refrain from any straining, so to prevent dehiscence. And they have to support their neck when they're rising or reclining. So any motion like this is dangerous. So teaching them to keep their neck straight. And then the other thing you want to monitor is for thyroid crisis. So if they have dysrhythmias, tachycardia, vomiting, nausea, confusion, you want to let the doctor know right away. So then the opposite is hypothyroidism, and that is when there is inadequate secretion of the thyroid hormones. So when this happens in the developmental years, that will cause permanent retardation in physical and mental development. It can also happen in adults, but it is reversible with treatment. Myxedema is a term that is used to define hypothyroidism, and that is because of the facial edema from severe long-term hypothyroidism. Not all patients will have myxedema, but you might hear that term thrown around, and that is referring to hypothyroidism. So here is a picture of an individual that had hypothyroidism in infancy while they're still growing. And this is a picture of myxedema. So that swelling in the face, especially around the eyes, is characteristic of when it happens in adulthood. So the causes and risk factors, the primary cause is atrophy of the gland after years of Graves' disease or thyroiditis. Primary hypothyroidism accounts for about 90 to 95% of all cases of hypothyroidism. So remember that the thyroid uses iodine to manufacture hormones. So goitrogens is a term that refers to foods that affect the thyroid from getting the necessary amount of iodine and suppress thyroid hormone production. So soy and gluten, turnips and rutabagas are examples of those kinds of foods that suppress the hormone production. If they had any treatment for hyperthyroidism, that could lead to the opposite, hypothyroidism. Iodine deficiency and defects in thyroid hormone synthesis. So you may notice that some foods are enriched with iodine, like salt, for example, and that the idea behind that is to prevent hypothyroidism. Then the secondary causes could be to a deficiency of thyroid stimulating hormones, so related to either pituitary or hypothalamic disorders. And it could also be from the thyroidectomy. So if they had a tumor in the thyroid that they had to remove it for, that can lead to hypothyroidism, or even if they had hyperthyroidism and they had surgery to remove it, can lead to hypothyroidism. So here is a picture to help you remember this one. So it's kind of the opposite of hyperthyroidism. So instead of being always hot, they're going to be always cold. These are the people that will have weight gain no matter what. They will try to eat less, go on a diet, but they'll still have low metabolism and gain weight. They'll have the swelling of the lips and eyelids, like the myxedema we talked about. Their skin will be dry and thick. They are more susceptible to bruising. They will also have thin and coarse hair. They can have hoarseness, non-pitting edema that is generalized, so different from Cushing's where it's just focused in the abdomen. They can have facial edema, so the mixed edema. And then their appearance, their affect will be kind of slow and low, kind of apathetic. They will also have pallor associated with anemia. And then they can have menstrual irregularities. They can have numbness and tinglings of the arms and legs, and intolerance to cold. So the medical diagnosis is also done on lab testing of free T4 and TSH. So the T4 is going to be low with hypothyroidism, except for when the problem is tissue resistance to the hormone. As far as complications, they could end up in a myxedema coma, and that is characterized by hypothermia, hypotension, and hypoventilation. And that can be precipitated by infection, trauma, if they get really, really cold, or as a side effect from some drugs. And in the medical treatment, they will have hormone replacement therapy. So very common, you'll give this medication a lot in the hospital, Synthroid, which is a levothyroxine that is given usually in the morning before breakfast. And then Cytomel is another one. So teaching for these patients as far as the medical treatment, they will start the Synthroid or the Cytomel at a very low dose, and then they allow the body to adjust it, and then they slowly increase it until they get it to where they want it to be. So it's really important to teach them that if they miss a dose, you don't want to double up the next day because it's very sensitive. And it'll take several weeks for them to notice the effects. And also teach them to know the signs and symptoms of hyperthyroidism. So especially during this trial period, if they're having the opposite effects that they usually have. So now all of a sudden they're really hot, their heart rate is high, then there might be that the dose is a little bit too high. So they have to let the doctor know right away so they can lower that. So for nursing diagnoses, activity intolerance. So they have low energy levels, they tire really easily. So you want to plan care accordingly to allow for rest periods. And these people are already low metabolism, tired. So you don't want to give them too many sedatives. So like with the hyperthyroidism people, you want to discourage them from drinking caffeine. These people have to be careful with sedatives. They're a little bit more sensitive to them. Imbalanced nutrition, more than body requirements. So they might need to reduce their caloric intake so they don't gain excessive weight, which just puts them at a risk for a whole bunch of other things. Hypothermia, they're at risk for that. So they'll need blankets, regulate their temperature, avoid prolonged exposures to cold. Constipation is common. So because of their decreased metabolism, you want to encourage them to drink lots of fluids, eat a lot of fiber, and increase physical activity as much as they can. Risk for impaired skin integrity. Their skin is drier than normal, so they're prone to skin breakdown. You want to encourage them to use lotions to keep their skin moist. And then encourage them to elevate the lower extremities when they're sitting or laying to avoid edema. As far as decreased cardiac output, they are at risk for excessive cardiac stimulation after hormone replacement therapy. So then you want to monitor for any changes in heart rate. So like we talked about, when they're adjusting the medication, if they feel like they're having heart palpitations or something, they need to let the doctor know right away, because that can mean that the medication dose is a little too high. Fatigue for obvious reasons, their decreased metabolism, disturbed body image. So the weight gain can be pretty hard for these people, or the mixed edema, the swelling in the face. So education, encouraging the patient, and then deficient knowledge will be related to the medication regimen. So teaching them to take their medication as prescribed, don't double up if you miss a dose, and then the signs and symptoms of hyperthyroidism. So tachycardia, if they're all of a sudden losing too much weight, or they're more nervous and irritable than normal. So another condition is a goiter. And that is when the thyroid becomes enlarged with normal hormone production. The causes for that could be iodine deficiency, long-term exposure to the goitrogens that we talked about earlier, those foods. It also might be enlarged to compensate for hypothyroidism, it's overacting. And then if it's producing excessive hormones, then they can lead to hyperthyroidism. So for the treatment, if it's mild, usually they don't need any intervention. Some patients might need hormone replacement therapy. And if surgery is indicated, surgery will be indicated if they have pressure on the trachea that's compromising their airway or in the esophagus, or if the condition is disfiguring. But most of the time, they don't need any surgical intervention. So here is a picture of a goiter. And that can happen also from other disease processes, which are not part of this unit, but mumps usually causes a goiter. And then the thyroid can have nodules. So these can be benign or malignant. And it's referred to as multinodular goiter. So it's different from the simple goiter. And this is the one that can happen with women later in their life, ages 60 to 70s. And this is more likely to happen in people that have had a goiter for a number of years. So the simple goiter can progress to multinodular. And they will do a radioactive iodine RAI scan to determine if there is cancer or the extent of the tumor. These can usually be surgically removed, the nodules. And if it's a benign condition, they won't remove the entire thyroid because then they have to be on hormone replacement for the rest of their lives. So they'll just remove the nodules if possible. And then there's thyroid cancer, which is uncommon. And it's not a very deadly cancer. Less than 1% of the cases are fatal. The early stages, what people will notice is enlarged lymph nodes in the neck. They might not have dramatic effects of the hormone level disturbances like the hypothyroidism or hyperthyroidism. And then if they do have cancer, they will remove the entire thyroid. If the cancer spreads beyond the thyroid gland, then they might have to have a more radical surgery, so removing the parathyroid and any other areas that it metastasized to. The 5-year survival rate of thyroid cancer is the highest among any type of cancer because usually it doesn't metastasize outside of the thyroid. So it's pretty contained. So if they remove the thyroid, it goes away. People don't have any problems after that. So then the long-term treatment as a result is just like if they had hyperthyroidism and they remove the thyroid gland, they will have a likelihood of having hypothyroidism. So they'll have to be on medication and also be aware of the recurrence of the cancer. So as far as the parathyroid glands, anatomy and physiology of those, we talked about it a little bit with the surgery, the thyroidectomy. So that will be the smaller glands that are behind the thyroid. And they could also be found in the mediastinum for some people. So there's usually 4 of them, and they function independently. And their function is to secrete the parathyroid hormone, or PTH, which regulates serum calcium level. And here is a picture. So, whoops, there is the parathyroid glands right there behind the thyroid. So, nursing assessment related to parathyroid conditions. Note any changes in the mental health or emotional status. They might have problems with memory, personality changes, irritability. Assess if they have a history of musculoskeletal problems, so weakness, skeletal pain, backache, twitching of your muscles or spasms. That is going to be related to the hypocalcemia. They might also have urinary frequency, polyuria. They're more prone to having urinary stones, kidney stones, or constipation. And then past medical history of the head and neck. Did they have radiation? Did they have surgery to remove the thyroid? Do they have chronic renal failure? And assess what medications they're on. Are they taking calcium supplements or vitamin D? As far as the physical examination, you want to know the heart rate and rhythm, blood pressure, respiratory effect, twitching of the muscles, hair and skin texture, and then the Chvostex and Trousseau sign are both tests that are indicative of hypocalcemia. And then a little picture for you to remember hypocalcemia, signs and symptoms. So CATS, convulsions, arrhythmias, tetany, and then stridor and spasms. So as far as the Chvostex and Trousseau sign, be familiar with the definitions for these. They both are used to determine hypocalcemia. The Chvostex sign is when you tap the patient's facial nerve and then they'll have a spasm on their face. And then the Trousseau's is when they have carpal pedal spasm and the blood pressure cuff is inflated above their systolic pressure and left for 2 to 3 minutes, they'll have the spasm of their hand. So here's a picture of the Chvostex sign where you tap them in the face and they'll have twitching of the facial muscles. And then the Trousseau's, so the hand movement there, that is the spasm of the hand when you do the inflate the blood pressure cuff. So if anybody has a handy way to remember that, the difference between those two, I don't have a good mnemonic for remembering that. But Trousseau is the blood pressure cuff one and Chvostex is the facial nerve one. I guess you can Chvostex cheek maybe to help you remember. Okay, so then the parathyroid diagnostic tests, they will do blood tests. So check the serum calcium, phosphate, creatinine, uric acid, magnesium, phosphate, and PTH. As far as imaging, radiographs can show, that would be actually EKGs. They will show a calcium imbalances because of alteration of electrical activity in the heart. So just like the elevated potassium. Dental examination, that will detect any changes consistent with the parathyroid dysfunction. And then the radiographs is to see if there's excess calcium loss from the bones. So they'll have demineralization of the bones. So then characteristics of hyperparathyroidism, that is when there's excess secretion of the PTH. People that are at risk are people that have been on dialysis for a long time, or if they had a kidney transplant. Then the most notable effect is elevated serum calcium, high parathormone, and that will cause the calcium to shift from the bones into the bloodstream. So that's when you'll see the hypercalcemia in the blood test. So causes, it could be due to an adenoma, so tumor, benign or malignant. It could be due to vitamin D deficiencies, malabsorption, if they have chronic renal failure, if their phosphate level in their blood is too high. And it also could be a result from exposure to neck radiation in childhood. So if they had some sort of cancer they got radiation for and the neck wasn't protected, that could lead to hyperparathyroidism as well. Hypercalcemia is the elevation of the serum calcium level. That is the most notable effect. And demineralization of the bone, because it's being pulled out of the bone and going to the blood, you will see that on the x-rays. So then a little picture there to help you remember hyperparathyroidism. The symptoms develop gradually and they're vague at first. So they'll have weakness, depression, lethargy, anorexia, and constipation. Other findings will include mental and personality changes. They'll have dysrhythmias because of the electrolyte imbalance, weight loss, and renal calculus. So with the calcium being pulled from the bones into the bloodstream, which is filtered by the liver and the kidneys, those excess calcium deposits can give a patient kidney stones. And they'll have poor muscle tone. They might have bone pain because of the calcium loss, hypertension, and they're more prone to fractures. So stones, bones, groans, and psychiatric moans. It's a good way to remember that one. So medical diagnosis, they will have, like we talked about, serum calcium level will be elevated, and that acts with phosphate, so then the phosphate will be decreased. They have the opposite effect on each other. They will do a 24-hour urine collection to detect for elevated urinary calcium. We talked about the radiographs, and then they could also do CT and MRI to evaluate the bones. So as far as medical treatment, if it is a tumor that is causing hyperparathyroidism, they will remove it surgically. But this is a complicated surgery because the glands are so small and they can be located in the mediastinum. They might have to transport the glands to other places in the body so they still have their function. So they can transplant it to a muscle in the forearm or the neck. That way it can continue to secrete PTH and not cause further problems. And if possible, they'll leave some parathyroid tissue where it was in the neck or the mediastinum, but they can move it if necessary. So the medical treatment, they will have drug therapy, which is aimed at lowering the serum calcium level. These medications include calcitonin, that is the most common one, and then those other ones, biphosphonates, methotrexate, but calcitonin, calcimar is the one you'll see the most commonly. And then Lasix will promote excretion of the calcium in the urine, so it doesn't accumulate and cause kidney stones. Calcinet is another medication, and that suppresses the PTH secretion. And then you also want to encourage increased fluid intake, so to promote excretion of the calcium in the urine. If they need to lower the calcium quickly for whatever reason, they can infuse normal saline IV. Yeah, that's it. And then Lasix to promote the excretion in the urine. So as far as assessment, you want to monitor vital signs, urinary output, make sure they're not holding on to fluid, the muscle strength and neuromuscular irritability, and then any digestive disturbances. And for nursing diagnosis for hyperparathyroidism, activity intolerance. So as with most of the other disorders we talked about today, plan your care to allow periods of rest. Risk for injury because of their bone being lacking calcium, they'll be brittle, so they're more prone to fractures. So if they're in the hospital, fall precautions, teach them to prevent falls at home and ensure their safety. Impaired urinary elimination, so you want to keep a close eye on their eyes and nose. They'll be on strict eyes and nose usually, and you want to monitor for signs and symptoms of kidney stones. So decrease the urinary output. The urine is becoming more concentrated, more likely to lead to kidney stones. If they're having sharp flank pain, I don't know if anybody has had kidney stones here, but I have, and it is not fun. So it's so painful that the patient won't be able to walk even, and they'll have diminished urine production. So that will be your key. And they might also have hematuria, which is blood in the urine. Encourage fluids and stool softeners to prevent constipation. As far as deficient knowledge, make sure you teach them signs and symptoms to prevent exacerbation, and imbalanced nutrition, less than body requirements. So take measures to control nausea and vomiting that can occur with this disease process. And then small feedings might be better tolerated. And if they do end up getting a parathyroidectomy, as far as post-op care, there's 2 potential complications. So one of them is airway obstruction, and that could be due to accumulated fluid and blood in the surgical site and compressing the trachea. So pay close attention to the respiratory status, monitor the rate, effort, and then also the pulse rate. If they're having increased respiratory rates and increasing pulse accompanied by restlessness, that means they're not oxygenating. So report that to the physician. They might need some intervention. And then they might need you need to have a tracheotomy tray emergency at the bedside, because they might need to have an emergency tracheotomy if the airway becomes compromised, just like if in thyroidectomy. So similar care to the thyroidectomy patient. So be alert for tetany, and the hallmark signs for that, which means that they have hypocalcemia, is tingling around the mouth and the fingers. If they're reporting that, notify the physician right away. That is how it starts out, and then as it advances, it could progress to severe muscle spasms or laryngospasm. And like we talked about, laryngospasm constricts the airway and it's very dangerous and life-threatening. So if they show those early symptoms of tingling around the mouth and the fingers, you want to call the doctor right away, so they'll prescribe calcium, either IV or oral, to treat that. You want to protect the suture line from stress, just like in thyroidectomy. So you teach them to support their head when they're changing their positions. Inspect the dressing the same way you would with thyroidectomy. So check the back of their neck, not just the front of the incision, especially when the patient is laying down. And you might have to elevate their head to reduce swelling. But do that very carefully so you don't strain the neck. And open up the incision accidentally. You don't want to do that. So we'll stop here today and pick up next week. So does anybody have any questions about anything before we go? Endocrine is not fun, you guys. So whatever you can do to help you remember the things. I know.
Can you just start from the beginning again? Just kidding.
Yeah, I mean, what helped me when I was learning all of that, because it's so abstract as far as all the hormones and everything, those little infographics, because I'm such a visual learner, helped me remember. So I would remember the person, what they look like, and that just the name of the disorder and the picture of what the person looked like really helped remember. And I don't know if you guys have looked in the resource folder yet, but I posted a bunch of videos, which helps me learn too. The crash course, AP crash course, is really funny. The guy has all these cute little drawings and explains it in a way that makes sense to me. So if that is helpful for you, please utilize those resources. And then I posted a bunch of videos too. I love that guy too. I posted some videos from, I forgot the guy's name. There's 2 of them. One of them is Nurse Blake, but they also explain things a little bit differently that might be making more sense for some other people. So Hank Green, is that his name? The guy from Crash Course? I like his videos a lot. It makes a lot of sense. So if you find a video that has worked for you, please share it with me. The ones from Nurse Blake and all that, it was a student in the fall that mentioned them to me, so I put them in there and that helped some people. So if you have any tips or tricks, feel free to share. Yeah, John Green's brother. Huh, I didn't know that. All right, so please let me know if there's any questions, reach out, and I will see you next week. And don't forget to take your test today. Are we still taking the ATI comp for this class? Yes. There is a folder. It should be visible now. Let me know if not. There's a folder for the ATI comprehensive exam. You want to do the practice because that'll help you get a passing score in the comprehensive that you have to take. So you can stay on the one-on-one for the RN program. If that folder doesn't open up, let me know. I think it's available now, the drop box for that. Cool. All right, well, see you guys next week.